Thank you. Yes. Thank you very much, Jacek, and really lovely to see everyone online, and especially to see our distinguished panel, as well as Sandy, who, as many of you know, or some of you might know, is the brains behind the UNAIDS PEPFAR Faith Initiative. So we really appreciate that you will be here, Sandy, facilitating today's discussion, which is a really important discussion. So my name is Muleya Mwananyanda, and I'm pretty new to UNAIDS. I'm the Director of Influencing and Partnerships, working with Jacek here, Francesca, and others, and really welcome you to this conversation today on the challenges to pediatric HIV care, which is being led by the academic consortium of the UNAIDS PEPFAR Faith Initiative, which once again is a really important conversation, considering just how little we've moved in terms of the response for children. And there are many things that really come to mind for me when I think about how children are often almost invisible. Last week, I was traveling in Croatia, and I was listening to a 16-year-old speak. And they spoke about how mental health issues were not regarded as one of the main things that are affecting children and youth generally, or kids, and that a lot of the responses don't address that. And therefore, for me, it's important to have conversations like this to just get a sense around how we intersect those things and how important it is, particularly for those people working in faith initiatives, to look at issues like that. And similarly, the COVID pandemic and its impact on children, and in particular on orphans. So I come from Africa, from Zambia, a country that, because of the HIV pandemic, we saw many families, including my own, having to really rally behind communities, and mostly behind faith initiatives like churches, some were mosques, to really get support from those, because these things often leave children really uncared for. And therefore, it's really important that we look at ways in which children are impacted, but also to look at what are the drivers and how do we really respond in a world that is so full of polycrisis, and is going through the crises, the many crises that we're going through. How do we center children, especially considering that the commission between WHO, UNICEF, the Lancet Commission, has also talked about how children should be centered in the Sustainable Development Goals. So I'm really excited to be part of this conversation and to learn from everyone, from the expert people that we're going to have here, from Susan Hillis, Victor Akello, and from John Blevins. Really welcome. Thank you very much for being here. We really appreciate that you took your time from your busy schedules to be with us and to discuss really this important topic. So thank you very much. And without further ado, I would like to hand it over to Sandy to facilitate the program this afternoon. Thank you.
Thanks so much, Malaya. It's wonderful to see you. I look forward to seeing you in person next time. But I want to say good morning, good afternoon, and good evening to all our friends, colleagues, and collaborators that have joined us on this call. Welcome, and many thanks for taking time with us to discuss this really important topic of reaching our children during the COVID epidemic and the impact that that had on our capacity to be able to reduce the impact of HIV on the children that we serve. I also want to just give a special thanks, as always, to Francesca Marico, who makes all the magic happen for us, and then the rest of us just show up and facilitate. So that's a really good thing. We are incredibly grateful to you, Francesca. I think actually Francesca is the brains behind this, and I'm just the brawn behind the project. So thank you, Francesca. But we have a great lineup of speakers and look forward to a lively conversation with questions and answers at the end of the presentations. But let's go ahead and get started. And I have the great pleasure of introducing our first speaker, Dr. John Blevins, who is known to most all of us. But John is an extraordinary leader in the space. He currently directs the Interfaith Health Program at Emory University at the School of Public Health there. He's a professor at both the School of Public Health at Emory University in Atlanta and teaches also at our School of Theology at Emory, the Candler School of Theology. But he's been involved in this project and many projects since the beginning, and leads our academic consortium with Dr. Esther Mambo. So John, let me turn it over to you for our first presentation.
Great, thank you, Sandy. And I do want to acknowledge that this is the information I'm going to be presenting on is the work of the academic consortium. And as Sandy mentioned, that is a joint initiative between those of us here at Emory and colleagues at St. Paul's University in Kenya. And Professor Esther Mambo is the principal investigator for the academic consortium and is a colleague with me in all of these efforts and on all of the output and the work of the academic consortium on the PEPFAR UNAIDS Faith Initiative. So I'm going to go through and share some findings from a report that we completed in 2022. I want to describe the findings from that study that calculated the percentage of treatment services that are offered by faith-based health facilities in Kenya and compare those findings to earlier waves of the study. We have conducted this study in 4 waves since 2013, and I'll be presenting on the longitudinal data related to that study to highlight the findings on the impact of COVID, particularly the years of 2019 to 2021 on HIV treatment visits overall, and then finally to highlight those COVID findings in the context of pediatric treatment visits in Kenya. So first, to tell you briefly about how the study is structured, we first needed to identify and to develop a list of faith-based health facilities in Kenya. We did that initially by looking at the Kenya Health Facility Master List that is maintained by the Ministry of Health and that is available on a searchable website. And allows you to identify registered health facilities in the country that's self-listed as faith-based. So our first inclusion criteria was any facility that was listed on the Ministry of Health's master facility list as faith-based. But we also knew, based on earlier efforts in this study and our work in Kenya and relationships with Kenyan colleagues, that a number of faith-based health providers in the country had identified or been identified as non-governmental providers, which is a separate category on the master list, but were not specifically listed as faith-based. And so we used a secondary screen of inclusion criteria for that subset of providers listed on the health facility master list as non-governmental. We included health facilities in that group as faith-based if they met one of 2 inclusion criteria. If the facility or the sponsoring organization of the facility listed religious beliefs as a core to their mission. So if on a website for the facility, we saw specific reference to religion and religious teachings, religious organizations as central to the mission of the organization, or the facility or the sponsoring organization of that facility had direct financial, administrative, or programmatic ties to religious bodies and religious structures. We listed those facilities as faith-based facilities as well. We then looked at all HIV clinical services that are now aggregated and captured and maintained electronically on a protected database, the DHIS2 data platform, available at hiskenya.org, but you have to be a registered member to access that data. And we've had the good privilege of being able to access that data since 2013. And went county by county to look at the percentage, the number of HIV treatment visits across different age cohorts is the denominator for our numbers of visits. And in the numerator, we pulled out the faith-based facilities for those counties, looked at the treatment visits that those facilities provided. What you see across the 4 waves of the study, studies done in 2014, 2018, 2020, and 2022 with data from the year before, is a remarkably consistent percent of HIV treatment visits provided by the faith-based sector, 22% in all 4 waves, with only 0.3% difference across the three groups. So, I'm sorry, 1.3% across the 3 groups. And then we saw an increase overall from 2019 to 2021 of 11.7% in the treatment visits across all age cohorts for all facilities in the country, and an increase of 10.8% among faith-based facilities. If you look at the top 10 counties in Kenya with the highest HIV disease prevalence, or the greatest number of HIV cases, and the highest HIV incidence, or the greatest number of new infections in a given year, looking at those 20 counties, there's tremendous overlap between the 20, and there are 9 counties that are in, 10 counties that are in, no, 9 counties that are in both, and 1 county that remains in each of the other 2, for a total of 11 counties. These 11 counties here are then the high priority counties across the country of Kenya for HIV response. And you see across these counties an even higher percentage of services provided by the faith-based sector in 2017, 2019, and 2021. These numbers don't include 2013 data, because the 2013 data we did not disaggregate by counties in this way. And so we see again a tremendously consistent percentage of services of about 24% by faith-based providers in the high incidence or high prevalence counties in the country. And then I just want to note that in the top 3, which are counties with high HIV disease prevalence and incidence of Mombasa, Nairobi, and Kiambu counties, you see a tremendously high proportion of services in those 3 counties that are provided by faith-based health facilities, 47% in Mombasa, 40% in Nairobi, and 32% in Kiambu. It's also important to note that in Mombasa specifically, the percentage of those services provided by faith-based providers, about 80% of all HIV faith-based treatment visits in Mombasa County are provided by faith-based, Islamic facilities and not Christian facilities. So in Kenya, Muslim providers are important providers of HIV services as well. So what does the data look like during the midst of the COVID pandemic from 2019 to 2021? Well, we saw an increase in treatment visits for both adults and adolescents. In adults, we saw an increase of 7.6 in all facilities, 7.7% in faith-based facilities from 2019 to 2020, and an additional increase of 5% from 2020 to 2021 for all facilities, 4% by faith-based facilities. And so across that time range of 2019 to 2021, we saw an increase of visits of 13.1% across all facilities and 12% in faith-based facilities. Similarly, in adolescent visits, we saw an increase during the COVID pandemic, 3.8% across all facilities and 5.4% in faith-based facilities, 2019 to 2020, 2.7 and 1.1% from 2020 to 2021. So in In the midst of COVID, we still saw increased treatment visits and coverage for adults and adolescents, but there was a marked decrease in pediatric treatment. We saw the number of treatment visits from 2019 to 2021 fall by 17% across all facilities and by almost 19% in faith-based facilities. You saw in 2019 a total of 428,096 treatment visits in 2019 and only 354,300 in 2021. What accounts for that drop in services? To try and answer that question, we developed some working hypotheses and then went back to the data to see if the data could tell us anything as to whether those hypotheses might be leading us to some insights as to what was occurring here or not. So first, we wondered whether the decrease in pediatric visits was simply a case that we've done really good in preventing new pediatric infections, and that as there are fewer pediatric cases occurring, the drop in treatment visits simply reflects the progress in the global response. And while it's the case that there has been a drop in pediatric cases, those cases dropped from 2019 to 2021 in terms of reported cases, according to UNAIDS data in Kenya, by about 13%. Treatment visits overall dropped by 17%. So it's not likely that this alone accounts for the drop in treatment visits that we saw, although it could account for some of them. Second, did the decrease in pediatric cases simply reflect difficulties in women who are living with HIV and aware of their status and have children living with HIV, difficulties that they had in accessing HIV services during the pandemic for themselves or for their children? We can't know this for sure in regard to the data we have available in front of us from the HIS Kenya website, but it's not supported by the data that we see for treatment visits for adolescent girls and young women. So we looked specifically at those two age cohorts of younger women of childbearing age, adolescent girls and young women from 15 to 24. And we saw for older adolescent girls, an increase in treatment visits of 14 and almost 15% over the course of the height of the pandemic in all facilities, and a greater increase in faith-based facilities of 17%. And for young women ages 20 to 24, we saw an increase of 8.2% across all facilities and 12.6% in faith-based facilities. So if women who were aware of their status and who had children who were also living with HIV, if they were not accessing care for their children, they were nonetheless accessing care for themselves, at least looking at these treatment data. And we don't see it as being a kind of plausible hypothesis that they would seek care for themselves alone and not seek care for their children. And so we then ask, is the overall decrease in pediatric visits disproportionately due in part to a failure to ensure that neonates who were recently born to mothers living with HIV are being referred into clinical care, being screened for HIV infection? We know of newborns living with HIV and that they're receiving care. And the data does support this, at least as being one of the drivers of these drops in treatment numbers. Treatment visits for children fell sharply over the course of the pandemic by 50% in all facilities in the country and by 57% in faith-based facilities. So you see this tremendous drop in infant treatment visits from 2019 to 2021, from 10,624 to 5,322, and in faith-based facilities, an even sharper drop of about 57%. So if we're seeing this sharp drop, and we're also seeing that treatment visits for adolescent girls and young women actually rose during the same period, it leads us to ask whether the decrease might actually reflect a breakdown in screening for HIV infection in women who are unaware of their status, and ensuring that prevention of mother-to-child transmission is in place for women who are identified as living with HIV. Prevention of mother-to-child transmission data from UNAIDS showed a slight decrease over the course of the pandemic, but still very high coverage of 96% in 2019 to 91% in 2021. But we did see a sharper drop, a far sharper drop in HIV testing among women who were unaware of their status, but received testing as part of general antenatal care services. 94% of women in antenatal care services received HIV testing in 2019 and only 85% in 2021, again, according to UNAIDS data. And so this leads us to some questions for further research. Did we see these changes and drops in treatment visits for pediatrics, and particularly for neonate cases and infant cases, as a blip in the data with a kind of recovery back to baseline after COVID, after we got through the initial COVID prevention response? And no, we don't see a recovery in visit numbers in 2023, looking at the 2022 data. Nationally, pediatric visit rates dropped by an additional 12%, and infant visit rates continued their drop at an even greater rate of an additional 14%. And so we do not see a recovery in pediatric or especially infant HIV treatment visits, even though we saw continued increases across all other age cohorts from 2021 to 2022. And so the next question to ask is, do these decreases simply reflect an uptake in multi-month dispensing of antiretroviral therapy? Possibly, and undoubtedly, MMD protocols could account for the fewer number of treatment visits, at least to some degree. But if so, why are we seeing this drop only in pediatric cases, and especially only in infant cases? We're not privy in the academic consortium to know what the protocols in Kenya specifically are around MMD. So if others on the call know this is something actually we would be interested in including in the discussion and hearing about from you. And then finally, a question for further research is looking at the PMTCT and HIV testing data for women. If we saw a small decrease in PMTCT from 95 down to 90 in 2021, and testing of HIV as part of antenatal care services for women who were not aware of their status dropping more sharply down to 85% in 2021, why this drop? Why this decrease in treatment visits in relation to PMTCT and HIV testing as part of antenatal care treatment during the period of COVID? And are we losing women for treatment of their own infection, women who are living with HIV but not aware of their status, and for preventing transmission to their children, or ensuring that if a mother does transmit the virus to her child, that child is receiving pediatric care? So what happened in that period of time in regard to those drops in numbers? The platform that we looked at for HIV treatment visits is not going to tell us that, but it is a question for further follow-up, and it dovetails nicely with the presentations both by Victor and Susan in regard to diving down a little bit further in regard to some of those issues, as well as an innovative response that Susan will speak to out of a faith-based response that was piloted in Nigeria. Thank you very much. Look forward to the discussion.
Thanks, John, so much. That was a fascinating presentation, and we've got some wonderful questions, but I think we're going to save questions till the end. So is that right, Francesca? Are we saving the questions to the end?
Yes, it is. Yeah.
Okay. Just wanted to make sure. Okay, so let me go ahead then and move to our next speaker, Dr. Victor Akelo, who is the Senior Public Health Officer at CDC in Kenya and the Site Director for the Child Health and Mortality Prevention Unit, who has got some really interesting data for us too. Victor, are you there?
Yes.
There you go.
Thank you so much, Sandy. Let me load it up. So thanks so much, colleague. Could you confirm you can see my presentation?
Yes, we can.
Yes.
Okay, thank you so much. So I'm gonna just pick it up from where Jonas left and share with you a little bit more on the gaps and challenges in pediatric HIV care, some sort of lessons and experiences that we have learned from Kenya Child Health and Mortality Prevention Surveillance Network, what we commonly call CHAMS. I won't talk so much about this particular slide because all of us understand the context about the challenges, and I think it varies by different reports, whether we are talking about UN units, UNICEF, etc. But just to mention that there's still significant amount of HIV infection in children and deaths in Kenya that warrant further investigations. There are limited data on the impact of HIV response on AIDS-related mortality, especially among children. And just borrowing from one of the reports that Jonas just alluded to about, talked about, the UNAIDS PEPFAR initiative, I picked up this comment that says, cannot know the number of deaths in children 0 to 9, data moots because HIV infection not a terminal condition in children living with HIV. So that provides a bit of some context that I will talk about, and also that the data indicates a significant gap in existing PMTCT coverage for women. So in our CHAMS, we reviewed HIV care continuum for 39 HIV infected children that were enrolled in Kenya between May 2017 and June 2021. CHAMS is a multi-country surveillance project that systematically track definitive causes of under-5 mortality from a defined catchment area and uses this data to inform policy and public health actions. The data for Kenya specifically is obtained from participants that are coming from Siaya and Manyata health and demographic surveillance systems, which are based within Siaya and Kisumu County. And those are some of the 2 counties in the 2 top 10 counties that priority in terms of the high HIV burden and new HIV infection nationally in Kenya, and also has a significant faith-based health facility providing HIV care and treatment. So CHAMS works through community engagements, talking a little bit about minimal invasive tissue sampling, which I will talk a little bit more about in determining causes of deaths, gets notifications about these deaths of under 5 within this catchment area. The ones that qualifies, enroll them and conduct minimally invasive tissue sampling using the minimally invasive tissue kit, the needle kind of shape that you are able to see. And then this package comes together through a panel of experts to determine the cause of death. This just summarizes some of those methodology that I've talked about. So we receive notifications, consent, and enroll them within 24 hours of death. Abstract clinical records about those patients, either facility, patient health records, conduct verbal autopsy, and some demographic surveillance data as well. Then samples that are collected through minimal invasive tissue sampling, including the lung, liver, brain tissues, the blood, goes for further testings that includes that multiplex PCR assay testing, HIV, malaria PCR testing, TB cultures, and some of them are sent to the CDC Central Pathology for special advanced testing. And then all these are brought together before a panel of experts that include pediatrician, neonatologists, obstetrician, epidemiologists that reviews these deaths. The packages are fairly very dense, if you can imagine all this data brought together, including the clinical records, and assign the cause of death using ICD-10, 11, and ICD-PM. This just gives you a bit of, again, I've talked a little bit about this, the culture, the HIV testing, pathology, histopathology, photography, physical measurement, and some data that are comes together in CHAMS. So sharing with you quickly about the results. So by the end of December 2021, we had determined causes of death for 662 child cases. And about 15% of them were either HIV exposed or infected, with about 61 HIV exposed but negative, and 39 of them that are HIV infected. It's this 39 that I'm going to deal a little bit more in terms of breaking down and examining what really happened for these 39 HIV infected cases. This is just a distribution of those 39 cases. You could see there was a stillbirths and neonates. infants about 8, and the number increases with the age of the child, with majority of the children 12 to 59 forming the bulk of these HIV infected children. So basically 88% of HIV infections were in children and infants, and about 13% could be talked about as intrauterine transmission because the stillbirths and early neonates testing positive for HIV, and some of them had pretty much significant high viral load. So I'll concentrate a little bit on these slides to talk a little bit about missed opportunities that we see in these cases. And in this particular one, talking specifically about the infant and the children cases, which are now reduced to 34, if I remove the stillbirths and the early neonates. So the HIV infected number is about 34. And of these, in trying to do some sort of pseudo cascade, we see that of those 34, about only 11 of them had HIV diagnosis before death. That's about 23. And even of this that had HIV diagnosis before death, and we could have that evidence from their clinical medical records, only 9 of them were actually on ART, which you could talk about as 82%. But none of them was actually virally suppressed by the time they were dying. So other way of looking at it is about 67 of these HIV infected children had a none or no HIV diagnosis. But interestingly, 6 of them had some documentation that shows that they were on ARV prophylaxis. So 3 infants and 3 children. By the time a child is more than 12 months and they're still on ARV prophylaxis, it raises the question whether they were being managed as HIV seroexposed rather than some sort of testing that should have been done to pick up the cases. And then of these 11 that had a HIV diagnosis made before they died, 9, as I've mentioned, were on ART, and 1 infant and 8 children. But none of them, as I've mentioned, was virally suppressed, and the viral load ranged from 1,000, over 1,000 to 90,000 copies per ml. Looking a little bit more on the maternal HIV abstraction data for these cases, about 19 of the women, close to about over half, were documented as HIV positive. 4 of them, which is 10%, were documented as HIV negative. And one of them had 1 negative test in the second trimester, but there was no repeat testing that was done. And this mother, following up after CHAMP's delivery of the result and further testing, was indeed HIV positive. And then 11 of them actually didn't have any documentation about their HIV status in the medical records that we had access to. And of those 19 that were HIV infected mothers, about 68% of them were on ART. This slide just talk a little bit about where the children died. So 22 died in the hospital, 18 at home, and 4 essentially en route to the hospital. So we had about 64 of the HIV infected children died at the hospitals, which also sort of raises the question about the access to HIV testing within the wards. And about 80 of them had at least 1 previous hospital visit, which was an opportunity to be able to do some HIV testing. Quickly turning into the causes of death, this first slide just gives you the overall picture of the causes of death for infant and children and underlying causes of death. And we can see malaria, HIV, malnutrition being the significant, contributor to causes of death among these particular children. So HIV plays a significant issue as an underlying cause of death for these children. It's important to know that 73% of these cases had more than 1 cause of death, and 44% had at least even up to 3 causes of death that were picked up during CHAMP's cause of death determination. Malaria similarly was significantly higher in Kenya and Sierra Leone, which is also one of the sites that participate in this. So we do operate in Western Kenya that has high prevalence of malaria. So you could see all these other diseases also contributing to causes of death to just provide some context. But now specifically looking at this, the one for the children, We see pneumonia, malaria, sepsis, gastroenteritis as some of the immediate cause of death. And 3 cases, for example, that had malaria was cerebral malaria. Some of the etiologies for pneumonia and sepsis are Streptococcus pneumoniae, Klebsiella, cytomegalovirus. But when you look at the underlying cause of death for this immediate cause of death, there were close to about 13 of these children that had HIV wasting syndrome, which essentially is WHO stage 4 severe symptomatic disease. And HIV with multiple infections, malaria, HIV disease unspecified. So again, underlining opportunities for potential testing, especially with children that had significant wasting. Turning it a little bit on the infant, we could see pneumonia, sepsis, pertussis, aspiration pneumonia, and a couple of those others as some of the immediate causes of death. And again, underlying HIV infection, HIV with multiple disease, and 2 infants having severe wasting and unspecified disease also in that order. Etiologies for pneumonia, again, didn't change so much: Klebsiella, Streptococcus, cytomegalovirus, and etc. This slide just talked a little bit about some of the causes of death. 97% of the HIV deaths had other infectious etiologies, lower respiratory infections, sepsis, and some of the top pathogens that we have already talked about. And this is just, it was interesting that we saw quite a significant number of CMV, cytomegalovirus disease, as either sepsis or pneumonia. And we could see that it underlined, it was a immediate cause of death, not only among HIV infection, in HIV children disease, which are 52, but also children that had malnutrition, low birth weight, prematurity, and even birth defects. Some of the DCODE panel also do make recommendations on what are some of the gaps that we realize, and this is just a summary of the gaps: adherence to national guideline, utilization of every opportunity on HIV testing, linkages and integration at default at tracing are some of the issues that needs to be strengthened in the HIV area. So in summary, majority of HIV infection deaths had advanced HIV disease with wasting, Streptococcus, Kleb, cytomegalovirus being common infections. The immediate cause of death were mixed infections, and for those who died of malaria, we had a couple of them with cerebral. Severe, several missed opportunity and non-HIV diagnosis before deaths, non-HIV status but undocumented, maternal and non-HIV testing, lack of repeat testing. So they essentially give some credence to this unit's PEPFAR Faith Initiative conclusion about the gaps in care, which is high in not only in pediatric cases but also among young adolescents. So there are several limitations to this presentation. CHAM sample size is small. The community deaths were underrepresented. Majority of deaths were in the hospitals, and CHAMS Kenya only enrolls deaths that are only enroll deaths which likely overestimate the population MTCT, and could be also representative of the hard-to-reach children who underutilized healthcare. Inadequate medical record documentation and data not disaggregated by faith-based and non-faith-based facility. So in summary, while Kenya has made significant strides, there's still significant gaps in HIV maternal and child care, missed opportunities that needs to be looked into. Children living with HIV tend to have multiple conditions contributing to their deaths. And the most common other causes of death in children yield insight that needs to be looked at to be able to have the greatest impact. And then generally improve focus on antenatal care, index of suspicion for HIV infection, and routine clinical audits of the HIV cascade care should be encouraged to eliminate pediatric HIV deaths and improve maternal HIV care. So I would like to acknowledge the following, and thanks so much for listening to me. Over. Thanks.
Thanks, Victor. That was absolutely fascinating and very, very interesting data. So let's go ahead and move to Susan Hillis. Of course, most of you know Susan already, but Susan is, Dr. Hillis is our senior advisor for the Community and Faith Initiative at PEPFAR at the State Department in Washington, D.C. She has been a senior leader at CDC for many, many years, and is one of the world's leading authorities on orphans. So Susan, let's go ahead and let me hand it over to you. Susan, can you hear me? Susan?
Okay, I was not getting, I think the host had muted me. So here I go. Thank you so much. I was pushing that button like mad, but not succeeding. I just want to honor and thank John and Victor and everyone who works on CHAMPS. It's exactly the kind of data I think we're needing. And it is quite disturbing, and I think highlights the usefulness of community-based and faith-based identification of children, of women who are at risk, and of women who we actually can, pregnant women for whom we can find out their status. Okay, the Baby Shower Initiative, from science to program. My background is so many years at CDC makes me love science, but my current work at PEPFAR for the past 5 years makes me so passionate about us figuring out together how in the world can we really be more, act more quickly to translate the science findings to effective programs. Next slide, please. So here's an overview of the Baby Shower Initiative. It's a community leadership approach to preventing mother-to-child transmission of HIV. And there are 4 things it does. First, it promotes early identification of pregnant women. So it seeks them out to find them instead of just waiting for them to come. So it's basically active surveillance of pregnancy rather than passively waiting for pregnant women to come to a facility of some type. Then second, early identification of risks among pregnant women, primarily through testing and this survey. And then 3, management of risk to reduce morbidity, mortality, and transmission to infants and partners. So really following up to ensure treatment. And then finally, identification and care of infected and affected infants. And again, by actively doing case finding and actively ascertaining which infants were affected or exposed. Next slide, please. So this congregational approach, it sometimes is called congregational approach, sometimes a baby shower. It has been implemented in Christian, and it has currently been being implemented in Muslim settings with adaptation. But there are these 3 main components: church sensitization by the priest or pastor or imam, by the trusted faith leader, about the importance for women who are pregnant to really focus on their health, because it's not just their health, but also the health of their babies. Baby shower activities are listed here: prayer, health education. Celebration is really key, and it's one of the things that we believe really draws the women in. Safe Mama Pack is a gift that she receives. Health screenings, including HIV and others, and then referral to antenatal care. And then really importantly, some of those same people that are serving as church health attendants or assistants actually then go find the pregnant women after delivery and do community follow-up to be sure that they're getting diagnostic sampling on the exposed infants. Next, please. So the prevention components are just shown here, really emphasizing, even by posters in the churches or in the mosques, the positive benefits of testing, really influencing the opportunity for a healthy child and a healthy life, emphasizing that medical visits are important, and emphasizing, especially with this malnutrition data that we had, it's important to recognize that eating healthy does really provide good quality of life for the woman and the baby. Next slide, please. There is a video here on the baby shower that I'm skipping over because you're going to see it when the pediatric compendium is launched soon by UNAIDS. So I won't going to go into that, but you do have it. It's about 1.5 minutes. It's fascinating. But the baby shower framework, this is a slide from the first randomized trial that actually was 10 years ago. And I cannot for the life of me figure out why we have randomized trial evidence from 10 years ago. Nigeria has implemented baby shower pretty widely, but other countries have not. And we're really excited that there might be I'm hearing that there's some potential from some of you in Kenya. And I also know that it will be implemented in Tanzania this year. So once you get into what actually happens, this is what happens. There's a prayer session, a baby shower, and a baby reception. The prayer session occurs every Sunday in participating churches. That is what happened in the actual study. What happens in the program is once every 3 months, there is a special prayer session and recognition session for the pregnant women and their partners. Again, there's identification and recruitment of pregnant women and their male partners. Now, it's really important to emphasize it does not matter for participation if the woman is married or not married or has a known partner or not. There are many women, pregnant women who are single who participate, and there are many pregnant women who have male partners and are not married who participate. Baby shower then occurs after the prayer session. It's kind of like edutainment because they actually make it fun. There's dancing, there's singing. And at the end of this special meal and receiving a gift, there's on-site integrated testing. And again, you see there HIV, hepatitis B, and later sickle cell testing as well, a health assessment and clinical referral for any women who are positive. And if they need accompaniment, then accompaniment to the facility. And then after birth, there's a baby reception whereby the woman who goes to that church or her husband or partner goes to the mosque, they come back for a special gift and newborn testing, and again, more dancing and singing and celebration and linkage care for the baby. Next slide, please. As an epidemiologist, I will say that these results are shocking. And so let me start with what happened with confirmed testing among the pregnant women. And among women who were in the intervention group, that is, participated in the baby shower, 92% of them were HIV tested in pregnancy. However, among the control population who did not participate, less than 55% actually were even tested for HIV during pregnancy. This is something unique to Nigeria. I don't think other countries would be that low, but we don't really have data on other countries in comparison populations that are similar to the population going to the churches. And you see then the bottom, the adjusted odds ratio. What this means control versus intervention is that among those women who were not participating in the baby shower but were pregnant, they were 11 times more likely to have no HIV tests at all during pregnancy compared to the intervention group. So we're really not thinking about the question, is the baby shower better than a facility model? We're really thinking about, is the baby shower better than what is just normal practice for pregnant women? And that is a very important distinction. Next slide, please. So not only were we really impressed from these initial results, again, I will emphasize 10 years ago in the peer-reviewed literature, AIDS, highly influential journal, but because the women brought their male partners, we actually could learn about the status of the men. Now, the participants of male partners was nearly 90% in the randomized trial. In the field, it was a little lower than this, I think more like 65 or 70, but that's still a lot more than it normally is. And here you see confirmed testing among the partners, among those who were participating because the women they were in relationships with were in the intervention. 84% of those men who participated got tested, and among control men who are partners of pregnant women in the community, only 37.7% were tested. And again, the adjusted odds ratio is just shocking. Roughly, those who were in the partners of women in the community, not in the baby shower program, were 12 times more likely to have no HIV test at all during the time of the woman's pregnancy. Very statistically significant. Next slide, please. So I want to emphasize that in this time of PEPFAR, and again, I'm speaking for PEPFAR since I work there, and our country operational plans for 23 and 24, and our new 5x3 strategy, there's a big emphasis on integrated care and looking for opportunities to address HIV thoroughly and also other health conditions that are very important for the populations we serve. And what is fascinating is there are about 24 different studies that have evaluated the baby shower or the congregational approach. It shows effectiveness across multiple outcomes in randomized trials, as you see there in the box. Also in the field replication in normal conditions in Benue State in Nigeria, just published in PLOS One 2 years ago. I'll talk about that in a second, but I want you to look with me, please, at this circle on the right. All of these things that can be influenced by this baby shower initiative and have been demonstrated in randomized trials: anemia, family planning, hepatitis B, hypertension screening, sickle cell disease, cancer screening, HIV, cervical cancer, HIV, family-centered approaches, malaria, pandemic outreach, syphilis, and mental health screening. And it serves women and their partners where they normally spend time, often, certainly between every week and every month in the countries that are most affected by HIV in Southern and Eastern Africa. Next slide, please. And so I want to say a little bit more about, I had just described that not only in these gold standard conditions in a randomized trial did the baby shower work exceptionally well, it worked very well in normal implementation in the field in Benue State. So this study was accomplished in 2019 and 2020, I think 18 and 19, but I'm not published until 2021, so pre-pandemic. And the baby shower program now was scaled up to 80 churches in Benue State to see, does it work in the field? Next slide, please. And this is just some of the training for the implementing partners. Next slide, please. Here are some initial results from Benue State, Nigeria, across nearly 700 baby shower events in 80 churches. Over 10,000 pregnant women and 6,000 male partners attended the baby showers. So you can see there, it's like 62% of the pregnant women had male partners there. Many of them had missed out on key pregnancy prevention, pregnancy services to help preserve health in the women. 44% of those 10,000 women were not enrolled at all in antenatal care. 1 in 4 of the women and 1 in 4 of the men had never tested for HIV, and many women were newly diagnosed with HIV at the baby shower events, 2.9%. I'll show you in just a second a little bit more about that. And 93% of those newly diagnosed with HIV were linked to antiretroviral therapy. Now you may be thinking, oh, 93%, that's not good, it's below 95%. We're not talking about 93% versus 95%. We're actually talking about 93% versus, for many women, nothing if they were never going to be diagnosed with HIV in the first place. Next slide, please, because they would not have gone to care. So here are the results in Benue State that I was just alluding to in Nigeria. And I want to emphasize what's in the light blue box. The baby shower intervention complemented facility-based approaches and reached women and their partners who would otherwise not have access to facility-based care. And those are all the ones, John, that like you didn't, we couldn't know what happened to them in that Kenya data. And actually, we're demonstrating that by engaging women with people they trust where they're already going, who are pregnant during the time of pregnancy, actively, we can find them and we can serve them and we can actually prevent perinatal transmission. So here you see in the bar graph, the proportion of pregnant women with newly diagnosed HIV infection at baby showers versus antenatal clinics. So first of all, we are finding the greater risk group because there's 2.9% in the baby shower model of women newly identified as HIV positive, contrasted with 2.1%, a lower percent in standard antenatal care treatment. But also the 2.9% does have 93% viral load suppression. The 2.1% in the antenatal clinics has 96% viral load suppression, which is better. All of us would agree that it's better. However, what we're really looking at is many women would never have gotten to that facility. And those are a lot of the women who are accessed by this baby shower model. Next slide, please. And great. I pulled some of these peer-reviewed papers in the Lancet in 2015. You know, it's the highest impact journal in the world. We see this effect of a congregation-based intervention on uptake of HIV testing and linkage to care in pregnant women in Nigeria, a cluster randomized trial. So basically state-of-the-art gold standard. You see here that underneath there was a commentary on the article proposing that it's possible for all of us to learn about increasing PMT-CT uptake through integrated faith-based activities. And then on the right, you'll see the PLOS One paper that came out showing targeted testing for male partners also was effective in identifying a large number of HIV positive men who otherwise likely would have been identified much later, if at all. And then the PLOS One paper that I'm not showing is one that also came out in 2021 to show effectiveness in the field. Next slide, please. And that's really our question. how can we take this science and move it into the field? We're working very hard on this at PEPFAR. I'm on calls about it with our leads, our science leads. A lot of the leads for those randomized trials are now working with us. PEPFAR capacity building tools for baby shower replication are close to being ready. There are the ones that were used actually for those studies, but we're converting them into tools that any partner could begin to at least review. And we are encouraged that training will be more and more possible. But we do have modules, module drafts for modules 1 to 6, and they're near completion. And you only need about 6 modules to do this well. And next slide, I think that's it. Oh, I was going, not quite. So I do want to mention that the baby shower does support the 5x3 strategy. This was presented at the UN General Assembly, UNAIDS PEPFAR Faith Leaders Breakfast, but it is so important. I think it's worth highlighting. Again, for those of you who are not there, we are addressing health equity priorities by closing gaps in pediatric HIV and promoting maternal and child health. We're promoting sustaining the response by strengthening community leadership, including faith community leadership by trusted leaders. 3, we're strengthening health systems and health security by leveraging PEPFAR platforms to collaborate with faith platforms and improve maternal and child health programs and systems. Transformational partnerships. They are such impactful partnerships when you can bring governments, donors, and faith communities together. Our data demonstrates that. And following the science, we are really encouraged and hopeful that more and more will see action that is at the program level based on this excellent science I have reviewed to basically promote prevention of the very disturbing data that were presented at the beginning of this talk. And then the cross-cutting different pillars at the bottom, enablers at the bottom are for innovation, certainly focusing on celebration. We have felt like is key from other evidence, not just what you're sick with, but what is worth what can you be positive about in your life, the pregnancy, the new birth, leading with data. There are standardized tools available, and community leadership. The community trusts the faith leaders as partners, as Reverend Dr. Makonda was sharing with us on a different webinar that several of you participated in last week. And with that, I'll close. And I think we're over back to you, Sandy, for moderation.
We go. Susan, thanks so much. That was incredible. All these presentations have been incredible. But let me look here and just let me start with you because we've got a couple of questions. Sonia was asking, does the baby shower intervention also link to non-clinic based interventions such as home-based care programs? Could you talk about that a little bit, please, ma'am?
Yes, while the baby shower model in its ideal implementation would link to clinic-based models in settings where clinic-based models are not available and traditional birth attendants are what is normally used, they certainly can link to those. I do not know if they are linking to some of those in Nigeria. I can find out if you want to send me an email. Nigeria, it's fascinating. It is the country where it was innovated, trialed, and now it is being scaled more and more. Particularly, there are some parts of Nigeria that are showing 5% perinatal transmission. And I know overall Kenya, Victor, from what you showed, it was like over 11%, which was shocking to me. I didn't know it was that high. Hopefully it's gone down since 2018, which was the date of your data. But there is certainly every reason to expect that you could certainly link to a traditional birth attendant kind of system if that's what's in place and a facility is not close or accessible by the pregnant women. Thank you for the question.
Okay, Susan, and one more question. This was from Stuart, and he was interested to know if the what I can't talk this morning, adaptations of the baby shower model have been made for a Muslim context and what the results have been.
Yeah, thank you so much. So Stuart, that's a great question. That adaptation is actually being implemented in the field right now. Data showing the impact are not yet available, but we are all waiting and excited about it. And as we all know on this call that typically it is the men who go to the mosques for the frequent prayers, but there are also special groups for the women at hours other than the men's prayer time. They meet less frequently, but they're leveraging those social networks of the spouses of the men who go to the prayer meetings. And they're also communicating and raising awareness with the men about the importance for their partners or wives of being sure they have some time to celebrate the pregnancy. And also they'll receive a gift, a mama pack. I didn't talk about that, but part of what the program does is provides a gift for the male partner to give to the pregnant women, or for someone in serving at the church to give to the pregnant women. So there's that positive benefit that is motivating. It's like an incentive for participation, and often just offering health education and health screening is something that's very positive. It's never been branded as an HIV program. It's always branded as a celebration and health program. And they always do screen for hypertension, diabetes, Hep B, and HIV. And you certainly could adapt it to what you needed to screen for in your local area. So hopefully I answered your question.
Super. And let me have one more question for you, and then I'm going to roll up to John and to Victor. But I think this is an important follow-on question. In lower prevalence, this is from Shafiq, in lower prevalent settings like Nigeria, a single test at a baby shower might well be a false positive. How is confirmatory testing done in those settings?
Yeah, that's really a great question. I'm going to give you I'll answer your question, but just let me tell you this, because I think it'll make you feel more confident. One of the things that I do in my job is I review all the modules that we have for the field, for the studies, for the baby shower, and together with our team, interagency team at PEPFAR, we determine, and for some of the innovators of the model, what is it that those implementing the baby shower as a program most need? Well, lo and behold, as I was doing the review last week of all the modules that are available, of about 150 slides, over 75 of them were on laboratory testing. And I thought, oh my goodness, don't tell me like half of it's the lab, but they are very careful. But so basically it's a 2-test positive algorithm. So, you start out with a rapid test, and, if the first one is, if that rapid test is positive, then you do a second different rapid test. And if that one is positive, then the sample is 2 positives or positive. If that one is negative, then you test with a third different rapid test. And if that one is negative, the baby's considered negative. And if that one's positive, the baby's considered positive. So basically, start with your first positive, then after that, up to 3 tests, 2 out of 3 positives is positive. But if your first test is negative, that is considered negative because of the sensitivity and specificity.
Thanks, Susan. That was really helpful. Okay, John, a couple of questions for you. Are you there?
I'm here.
Good. Okay. Stuart asked with your presentation, was asking if your research highlights what specific actions faith-based organizations and facilities should take to strengthen comprehensive PMTCT services and pediatric HIV services in 0 to 9-year-olds.
Not this study itself, Stuart. This study was simply looking at the health services data and calculating percentages of visits by the faith-based health providers across age cohorts. Your question is really important. And as you know, as being part of the PEPFAR UNAIDS Faith Initiative, it is a priority topic area and programmatic area for the initiative itself, both for pediatric services and prevention of mother-to-child transmission and adolescent services, and the contributions of faith-based providers for those groups. But this study itself didn't really look into that question. It was an analysis of health services data only.
Thanks, John. That's really helpful. And then a follow-on question, are there specific reasons for the resilience of faith-based programs vis-a-vis government health facilities during the COVID pandemic that you could identify, and what can we learn from that going forward?
I mean, again, from this study, we don't have any data from the study itself that points to the resiliency of faith-based facilities during the COVID pandemic. I think what we could say from lessons learned more broadly about the COVID pandemic is that it is essential in the midst of a public health emergency such as COVID, that established, trusted, long-term relationships are essential for ensuring that emergency services are provided and received in the community. And we know that faith-based facilities and faith-based organizations enjoy the social capital of those qualities of relationships across the culture and the community writ large. This study didn't look at that, but I think that's an important kind of reminder of the distinctive resources and contributions of faith-based providers in this regard. Susan had her hand up on that.
Susan?
Yes. As you know, and Stuart, you've just done a great job at assembling all the pediatric faith-based and faith-engaged models for pediatric care and treatment. But we do know from one of those included in that compendium that it's a Zambia model, and it's co-location on the grounds of a church or mosque of a small clinic, a container basically turned into a clinic that can serve, provide some basic services, including HIV testing. And we were able to learn from the population there that those were allowed to stay open during the pandemic, even though your larger clinics were closed, and that partially because they were so much smaller, and partially because whatever size the churches were allowed to assemble, Kenya had such a very specific guidance, like at what time you can have 50 people assembling, at what time in the COVID pandemic, for example. And once 50 people could assemble in a church, they also the government allowed, if there was a facility on site, to see up to that many people, I think, at a similar time period. So definitely the trust. And I think I saw Reverend Dr. Makonda on, and he has some survey data on the trust of Kenyans for the faith community versus the faith leaders versus other leaders. Nelson, are you on? Do you have that data? It was 70-some%, wasn't it?
He may not be able to unmute.
Okay, well, I see that I think it was around 73 or 74% versus, I think media was next and government was next. And clearly the faith leaders were the ones for whom there was the most trust.
There was one other question, and it was from Dr. Makonda, and I don't know if you saw this, Sean, because I want to make sure that I've gotten it right. And that is, could the drop in accessing services be attributed to mortality? And I think that was his question. I wanted to make sure I got it right. You may have seen it in the chat, John.
I did see the question. Again, from this analysis, we can't know, because the DHIS platform, at least the indicators we were looking at, we weren't looking at mortality data. If that's the case, that itself is a pretty damning statistic in regard to the endpoint of these drops being the death of children. It would be a kind of evidence of ultimate failure in terms of what we want to see in terms of treatment outcomes for children living with HIV if they died from HIV. And so I'm not making that claim. And actually, I don't think that is what these drops in treatment visits reflect. But if there is a rise in mortality rates that would account for that, that in and of itself points to a tremendous problem in terms of our network and our infrastructure for pediatric HIV programs.
And then I think Shafiq's question about, or could that be attributed to a possible success in PMTCT resulting in fewer cases identified through early infant diagnosis?
Yeah, I don't think that's the case, looking at the data a little bit more deeply. And the entire report that I was providing some summary data from is available on the Interfaith Health platform. Francesca has made sure that it's up on that site. And so you can see the full report. But when we look at that data, we didn't see We saw a decrease in the number of infections year to year, 2019 to 2021, of new pediatric cases, but not nearly the number of in terms of percent decrease as what we saw in either the 1 to 9 data set or the 0 to 1 for which would reflect prevention of mother to child transmission for pregnant mothers during that same time frame. We saw a decrease of about 12% in new cases from 2019 to 2021, but we saw a 50% decrease in neonate treatment visits. And so we wouldn't have seen that sharp of a drop if based on the number of new cases that were identified through UNAIDS data during that same time frame. So we had the same question, and when we looked at the data, it didn't indicate that that would have been the cause, the primary driver of the drop in treatment visits.
Okay, super. I see that Nelson, Dr. Nelson was on with us, and you all probably see this. It was the reason for this. We had 73% trust in faith leaders attributed to the engagement there. So that's amazing. But it just tells us that people listen to trusted leaders.
I will say that the academic consortium in 2018 also supported a master's degree thesis from a student at the University of Cape Town who is a medical doctor in a faith-based facility in Tanzania. So it's not in Kenya, but it's the neighbor of Kenya. And the findings from key informant interviews of people living with HIV accessing health services in those faith-based facilities in Kenya was exactly that they would travel further and go farther to and go to more effort to access services in a faith-based facility because they trusted the facilities higher. One of the not as positive findings from that study was that the out-of-pocket costs were significantly higher for people accessing care in faith-based facilities in that case study. And so it's not generalizable. It's a case study of one large inpatient and outpatient faith-based facility in Tanzania. But it does demonstrate that trust is a driver of people accessing services in faith-based facilities.
Thanks, John. Victor, let me ask you, Stuart had a question for you earlier, stating that since pneumonia is still a significant immediate cause of death in children, is contramoxazole prophylaxis still recommended treatment for HIV exposed infants in Kenya, and what's the level of treatment coverage?
Yeah, so thanks for that question, Sandy. So the answer is yes, it's still recommended for the prophylaxis. I think the latest data, and I may need to check this up, the latest data, the uptake is, the coverage is pretty very high. I think I saw ranging between 73 to close to about 90%. That is at us, I think 2020 thereabout. So yes, there is that coverage, but I think to just add a little bit onto that, to the context of this, these children, if you look at the pathogen that was the leading cause of pneumonia in these children, those pathogen, we have done a bit of some work that has shown that they were resistant to cotrimoxazole. So essentially, yes, you give out the cotrimoxazole, but there's significant resistance to cotrimoxazole for some of these pathogens. For coverage, such as for PCP, pneumonia, malaria, and others, yes, it still works, but then we still see these children dying from these other bacterial pathogens. Over. I can't hear you. I don't know whether you're muted, Sandy.
There we go. Yes. I was trying not to interrupt you. Thanks, Victor. That was very, very helpful. Let me just check. I think we've got we may not be able to get to the rest of these. So I think let me go ahead and close. There are a number of comments and questions that we will share and send to everybody, but I want to thank all of the presenters for their extraordinary presentations. They're just fascinating and so important. And of course, we'll share those, I'm sure, with all of you. But I just wanted a couple of, to wrap up with a couple of sort of reflections on what I'm hearing today and what we've been talking about sort of at PEPFAR and at UNAIDS for the last several months. And certainly, you know, that we know that we are not, we're not reaching children and mothers like we should, that we need to do better than we have been doing. And that's, you know, given all the evidence we have, the fact that we're continuing to fail is incredibly frustrating, I know, to me and many others. And I know our colleagues at PEPFAR and at UNAIDS. And I guess the next thing for me is just, and this is simple and we all know it, but we keep tripping over it, is that, you know, getting people connected to people that they trust in the community, particularly faith-based communities, for our hardest to reach population. You know, this not last 5% or 10% of people that we need to reach is absolutely critical. And we can't overemphasize that. And people seem to not be able to kind of grasp that. So that's another, I think, you know, reflection and some work that we all need to do as funders and donors in this space. So we'll get back to that and have some more conversations together about that. I think the other thing is that we need to collect, we continue to collect data. I mean, the data that all of you have presented is extraordinary, but you know, continues to you know, call us to answer more questions that we can share with others to change policies and, you know, resources and focus on these areas that are so critical to us, particularly children. And I guess the last thing that I find, and to Susan's point, is that you know, of course we need more data, but we've got really good data from things like the Lancet that are, you know, and the work in Nigeria and other places that's 10 years old. And why in the world are we not responding to that? We keep saying that we act on data and that we're driving with data, and then we have all this data and we're not driving with it. So there's a little bit of schizophrenia in our conversations around this that I think are important for us to continue to talk about. But all of this is so impressive, all of your data, and I think gives us great evidence and great ammunition to continue to support these kinds of dialogues and this kind of research. So I just want to thank you all for that. But let me go ahead and then turn this over to Rita for her comments. Rita is with Care30. Rita, are you there?
Yes, I'm here. Thank you, Sandy. Thank you for the wonderful moderation. Thank you. And thank you for the panelists for their wonderful complimentary presentation. But before wrapping up, I saw that Nelson had his hand up. I don't know if Nelson, you want to have a quick intervention?
Thanks, Rita. I didn't see it. Thanks.
It's okay.
Yes, I just wanted to say that we have initiated baby shower within a few churches in Kenya. We are doing this in Siaya, in Kisumu, in Homa Bay, Migori, and Busia, where we have the highest HIV prevalence in Kenya. Yesterday, we launched baby showers in Siaya County, and we are hoping that this will pick up well. The slides that Susan has shared are going to be very helpful for us, and any other technical assistance that we can get from this going forward. On the question that she had asked about the level of confidence and trust in the faith leaders, last year in a scientific study that was done by a professor of the University of Nairobi, it showed that faith leaders had 73% trust. It was the highest. The second one was median, with about 10 points lower. So it's indicative that faith leaders can be able to be used if we are willing to leverage and to engage them and give them the tools and data that is required for them to engage. Thank you very much.
Thank you, Nelson. And again, thank you for the wonderful presentation and how they complement each other's. It was really interesting to see with the Kenya studies that was presented by John, how resilient are the faith-based facilities during COVID and how it's important to learn from that for future pandemics. It was as well noting that although there have been a decrease in the pediatric services, but it was important and interesting to see how there have been an increase in treatment visits for adults and adolescents during COVID. I think after this, Victor has shed the light from a different perspective, from a medical perspective, showing and highlighting the fact that HIV remains a major cause of death for children, but there are still important gaps, not only in maternal, but as well in childcare, and there are missed opportunities that we are called now to look at it or even enhance our programs based on those missed opportunities, and how we can improve focused antenatal care, routine clinical audits for the HIV case cascades. And I think moving to Susan with the baby shower model, how impressive it is working with the community, this baby shower model that linked the church sensitization to activities, to communities. I think it highlighted the importance of integrated care, of reaching out not only to children, but to mothers, but as well as to their male partners who probably would have never went to the faith-based facilities if not of the baby shower model. And I think I will wrap up with what Sandy had, so we can enhance, adapt our projects, and basically make sure that we are really supporting the children who are in need. So basically, I would say thank you to everyone. It was really interesting to hear this webinar. It was so fruitful, and I think this is the way to share experience and continue together to support those children. I will hand it over to Jacek, and I just want to highlight the fact that all the resources will be uploaded on the Interface Health platform. So thank you, everyone. It was really interesting to attend this webinar, and over to you, Jacek.
Great, thank you very much. Thank you very much to all, to Rita, to Sandy for facilitating, and together with Francesca being the brain of all of this, to great presentations, to the content and to people behind it. Very big thanks to Martin and Mary for interpreting, to Cedric for facilitating. Final announcements before we close are that the materials for this from this webinar are already uploaded. So if you go to our event on the Interfaith Health platform, you will find the presentation, all presentations, main findings, and the report there, and recommendations as well. We will be uploading much more useful content on the page of Challenges to Pediatric HIV on our platform. Two specific announcements. On Monday, 26 June, we will be launching the Compendium of Promising Practices, as was mentioned by a few colleagues during this call. So you are all warmly invited to join us, even if it is the site event at the board of UNAIDS. It will be a hybrid event with the opportunity to join. The registration is or will be opened any moment at the link on the Interfaith Health platform. And the expectations for the compendium are already very high. We are pretty sure that after the formal launch, it will be even bigger. The second event that we would like to invite you all is related to a similar topic, but like from this different perspective. On the 29th of June, we will conduct, through the same modality as today, another webinar on maximizing the contributions of faith-based health facilities in HIV response. So again, I'm pretty sure all of you are interested. Those of you who are able to send out information about these two upcoming events are warmly requested to do so. Big thanks again to all of you. Stay safe and let's be in touch. Questions that were not answered, we will try to answer in the published materials from the webinar. All the best. Bye.
Thanks, everyone.
Bye-bye.
Thank you. Bye.